Good morning. As part of a series of recent advances in surgery faculty lecture, today we will have a faculty lecture on antibiotics in abdominal infections. If time permits, we'll proceed into WHO checklist, which is also important question for PG examination. So we start with the is my screen visible? Anyone can say?
Yes, sir, visible.
Okay, fine. So we'll discuss the practice of antibiotics in abdominal surgery. What are the current guidelines? So surgical site infection is the most common healthcare associated infection in our practice. And in GI surgery, the incidence is as high as 30%. Because GI tract harbors all types of bacteria. If you go with all types of bacteria, means I mean gram-positive, gram-negative, cocci, bacilli, anaerobes. All of these organisms are being harbored in GI tract. This surgical site infection increases the hospital stay, increases the cost of treatment. Some patient might require ICU admissions, require some invasive investigations, prolonged therapy, morbidity, and in some cases mortality. What are the different factors for surgical site infection? Some of these factors are preventable. The general measures include a good preoperative optimization, a glycemic control, maintenance of normothermia during prolonged operations, and perioperative supplemental oxygen. And prophylactic antibiotics has been accepted and proven method for prevention of surgical site infection. So different society has created guidelines for administering antibiotics in different abdominal conditions. So I'm not going to the details of each of these guidelines, but we will give an overview of what's the current practice for antibiotic policy in different abdominal conditions. There are some limitations in the abdominal literature, because once you try to compare the efficacy of prophylactic antibiotic versus no antibiotics, these studies are not being continued for long, because in most of the cases, the SSI rates are very low. And a small sample size increases the likelihood of error in this study. So it is difficult to establish that antimicrobial has got a beneficial effect. So what are the different antimicrobials used in our clinical practice? They can be broadly classified as bactericidal antibiotics, which will include cephalosporins, penicillins, fluoroquinols, glycopeptides, monobactams, and carbapenems. There are some bacteriostatic antibiotics, which include tetracyclines, sulfonamides, macrolides, and trimethoprim. And as per standard guideline, one should not use a combination of bacteriostatic and bactericidal antibiotics. So what are the different general principles for considering prophylactic antibiotics in GI surgery? GI surgery is taken as either is a clean contaminated, when you have controlled leak of GI secretions during surgery, or it can be a contaminated surgery when you have uncontrolled contamination of the operative field. And GI surgery has got higher risk of wound infection in view of the high bacterial load in the gut, and rate of surgical site infection is higher. And these are usually caused by a mixed flora, which can be either gram-positive, including Streptococcus, Staphylococcus, gram-negative rods, Enterococci, and Bacteroides. An appropriate antibiotic is important to prevent and treat this infection. So we have already discussed different risk factors for surgical site infection. These will include type of surgery, whether is a contaminated or clean contaminated or dirty surgery. The operative technique is important. If you have a good tissue handling, minimal blood loss, post-op, less chance of anastomotic leak, these are all important for surgical site infection. The length of surgery is important, so that if you prolong the surgery, you need to sometimes repeat the antibiotic dose. And pre-existing comorbid illness is one of the important factors. So how to select appropriate antibiotic in particular situation? The aim is to provide appropriate serum and tissue concentration of the antibiotics exceeding the MIC for the probable microorganism at the time of incision and throughout the procedure. So the pharmacokinetic antibiotic is important when you're using for a particular situation. One should be aware about the allergy to this particular drug, and one should be cautious about renal and hepatic functions if this drug needs kidney and liver for its extraction. The important drugs used in clinical include cefazolin, is a broad spectrum antibiotic and has got a half-life of 2 hours. It is said to be low cost, but even now ceftriaxone is of not very high cost, and ceftriaxone has got an advantage of it has a prolonged half-life of 8 hours, and plasma concentration remain higher than MIC for more than 24 hours. It has got a high protein binding, so for surgery for about 2 or 4 hours. If the patient is allergic to the first antibiotic, one need to use the second line antibiotics, and this in abdominal surgery includes vancomycin, clindamycin, gentamicin, or fluoroquinolones. What is the adequate dose? You need to give the adequate dose depending on the patient body weight, and if the patient is obese, you need to give higher doses. Standard dose of cefazolin is 1 gram. Patient 40 kg, double to 2 gram. If the patient is super obese, you need to give 3 grams. And if you are using cefazolin, just got a half-life of 2 hours, and the surgery is prolonged beyond 2 hours, you need to repeat the dose of cefazolin. What is the ideal route of drug administration when you're considering for prophylactic antibiotics? It is said that if you give an antibiotic as induction of anesthesia or within 60 minutes of the incision, an intravenous route is a rapid, reliable, and predictable route which provides good serum concentration with maximum bioavailability. Oral drugs are being used for colonic surgery, which is usually given the day before surgery. And if you have a super infection in Clostridia difficile or similar colitis, the oral drugs are effective. What is the optimal timing for administration of these antibiotics as prophylaxis? CDC recommends that administration drug within 60 minutes of skin incision to obtain optimal tissue and serum concentration. Preoperative dosing is required even if the therapeutic antibiotic is considered. What should be the duration of antibiotic therapy? If it's purely a situation you are using a prophylactic antibiotics, no additional dose are required after the surgery is over. There is no benefit of multiple doses over single dose. Unwarranted antibiotic administration can cause major cause for superinfection in Clostridium difficile. So if you go into each of these abdominal conditions, you can find out the indications and timing and the different drugs used for abdominal surgery. So what are the antibiotics for biliary procedure? For a routine laparoscopic cholecystectomy for gallstone disease, traditionally 1 dose was used. But it has been studied that there is no difference in outcome of SSI if you don't administer any prophylactic antibiotic. But in high-risk patient, like patient in more than 70 years, ASA grade 3, obesity, diabetes, non-functioning gallbladder patient is immunosuppressed, most prefers a single dose of prophylactic antibiotics for elective laparoscopic cholecystectomy. Some studies, however, recommends even prophylactic antibiotics for low-risk patient. It has been observed that prophylactic antibiotics reduces SSI in most cases of lap cholecystectomy. Prophylactic antibiotic is definitely indicated in patients who are undergoing surgery for acute cholecystitis. Patient has got jaundice, patient has got associated CVD stones, patient requiring conversion, or there is spillage of bile or stones during surgery. The usual antibiotic regime is cefazolin 2 gram or 3 gram depending on the body weight. And if not possible in the first line, it can be either clindamycin, vancomycin, gentamicin, or metronidazole. In other biliary procedures, routine ERCP, for diagnostic ERCP, antibiotics are not recommended. But patient undergoing ERCP for cholangitis, obstructive jaundice due to stones, one has to give a dose of antibiotics. The risk of SSI in open coli, CVD exploration, biliary bypass is 1 to 19%. So in addition to wound infection, other septic complications are common in these invasive procedures. And the rate of interval abscess is 1.8%. So wound infection and septic complications are higher in patients who are not receiving prophylactic antibiotics. The bacteriology in bile contains a mixed flora which includes commonly E. coli, Klebsiella, and Enterococci. Clostridia, it also contains skin isolates like streptococci and staphylococci. What is the antibiotic policy for treatment of acute cholestatis? In acute cholestatis, there is biliary infection with significant physiological derangement, and untreated acute cholestatis may progress and lead to severe septic complications. And severity grading of acute cholestasis is based on Tokyo guidelines. So, in grade 1 patient has got mild gallbladder inflammation. There is no organ dysfunction. Otherwise, healthy patient. The recommendation as per Tokyo guideline is consider lab cholecystectomy within 72 hours of admission, and 1 dose of prophylactic antibiotic is recommended before surgery. There is no definite indication for continuing antibiotics if the patient has got grade 1 acute cholestatis. In grade 2 patients, there is signs, symptoms of systemic inflammation. Patients got increased TLC, CRP. There may be local complications like pericholestic abscess and biliary pancreatitis, and there may be mortality of about 4.7%. In this patient, one has to start empiric antibiotic based on the flora in this biliary tree, and then the antibiotic has to be changed depending on the bile culture instead obtained during operation, and these are continued till the gallbladder is removed. Grade 3 is severe acute cholestatis with 1 or more organ failure. There is higher mortality, higher rate of systemic and local complications. So in these cases, one should start with the empiric antibiotic followed by therapeutic antibiotic. So this bacteriology in bile, as I said, it contains almost all the common gram-negative organisms, and it contains enterobacteria. For mild acute cholestatis, it can be either a ceftriaxone or cefotaxime. In moderately severe acute cholestatis, the recommendation is to give 5% tazobactam or cefoperazone sulbactam. So what is the strategy for antibiotic use in acute appendicitis? Acute appendicitis is the most common surgical emergency. The mainstay of treatment is appendectomy. In uncomplicated appendicitis, 80% patient has aspirate infection, and in complicated appendicitis, when there is gangrene, perforation, internal pelvic abscess, and generalized peritonitis. So these are the patient who has got more severe infection. And as in other cases of GI infection, it contains almost all the gut organisms like E. coli, other enterococci, the bacteriaceae, and the anaerobic streptococci and staphylococci. Prophylactic antibiotic in this patient who are undergoing surgery for acute appendicitis reduces the surgical site infection. In lap appendectomy, although there is less incidence of post-wound infections, there is higher incidence of organ-space infection. Some of these patients may have intra-abdominal abscess following lap appendectomy. So in uncompleted appendicitis, you can give just 1 shot of antibiotic, and there is no need to continue antibiotics in the post-op period. However, in complicated appendicitis like gangrene, perforation, or local abscess, you need to continue the antibiotic in the post-op period. And the preferred antibiotic is either cefazolin and metronidazole or second antibiotic with clindamycin and gentamicin combination. So another alternative is you can continue the second generation cephalosporin with cefuroxime or first generation cephalosporin with metronidazole. Another important area for antibiotic usage is acute pancreatitis. Acute pancreatitis is one important surgical emergency, and most of the morbidity and mortality are due to septic complications. Majority of these pancreatitis are self-limiting. However, a small proportion of patients with severe acute pancreatitis may progress with SARS or organ dysfunction syndrome. And it has been observed that in the course of 2 to 3 weeks, 20% of these patients may develop septic complications. So timing of antibiotic therapy in acute pancreatitis is important. So what happens as septic complication of acute pancreatitis? Once there is acute pancreatitis, patient has got acute paralytic ileus. There is bacterial translocation from the gut wall to the portal and systemic circulation. And if there is an associated biliary system obstruction due to stone, there is ascending biliary infection. There may be ascending infection of the duodenum through the ampulla water. And because of the ileus, there is bacterial translocation through the colon also. And this, like other GI infection, it can be a mixed flora, including anaerobes and fungi. So what is the role of prophylactic antibiotics in acute pancreatitis? This is controversial. Some do use it, but others decry. Severe acute pancreatitis in 50% develops infection and associated with increased mortality. Multiple studies has established the benefit of antibiotic in severe acute pancreatitis, but some studies also decry use of prophylactic antibiotic in severe pancreatitis unless there is documented infection superadded on that severe acute pancreatitis. So if you go to the different studies, before 2000, large series reported use of prophylactic antibiotic in severe acute pancreatitis, and it has shown significant reduction in mortality in antibiotic group. However, subsequent studies has not corroborated this observation. In recommendation of World Society of Emergency Surgery, they recommend routine use of prophylactic antibiotic is not indicated in severe acute pancreatitis unless there is documented infection. So what is infected pancreatic necrosis and what is the antibiotic policy? There is no controversy regarding use of antibiotics in infected pancreatic necrosis. However, the diagnosis of infected pancreatitis is difficult. One need to document that infection by doing a CT-guided FNA and gram strain of this aspirate. However, presence of gash in CT scan suggests infection. WBC count and CRP may be elevated in such situation, and procalcitonin is an important marker of infection. So what are the different antibiotics used in acute pancreatitis? It can be either quinolones or carbapinams. It can be iridopenicillins or third-gen cephalosporin. And a combination of aminoglycoside is not recommended always because aminoglycoside has poor pancreatic tissue penetration. Piperacin tazobactam may be the initial empiric antibiotic. It is gram-positive followed by antibiotic based on culture sensitivity, or it can be a carbapinams. There is no role of probiotics. There is no role of giving prophylactic antifungal in acute pancreatitis. However, if you treat this patient with prolonged antibiotics, there is chance of superinfection with candida, and in this case, you should treat candida infection either with capsofungin or fungin. Apart from this, there are other causes of abdominal sepsis, which can be either a perforative peritonitis or primary peritonitis. Abdominal sepsis can cause septic shock, which is life-threatening, leading to organ dysfunction and dysregulated host tissue response to infection. And this abdominal sepsis can have organ failure, which can be assessed by SOFA scoring. Septic shock is a situation when you require vasopressors to maintain a mean arterial pressure of 65 mmol mercury and serum lactate of more than 2 millimole per liter. It can be either a primary peritonitis or spontaneous bacterial peritonitis. It can be a peritonitis due to hollow viscous perforation, or it can be a tertiary peritonitis when there is recurrent internal infection following sepsis after source control. That means you have a cruzal perforation, that perforation has reopened up and lead to a tertiary peritonitis. And this tertiary peritonitis, that means leakage of anastomotic site or perforation being leaked, happens more in critically ill patients and in multi-drug resistant organisms. So how to manage abdominal sepsis? Early diagnosis is important. Source control by debridement and making a stoma for perforation is important. The removal of infected devices, prosthesis, drainage of pus and decompression of abdominal cavity is important for early control of sepsis. So there is a recommendation by Surviving Sepsis Campaign for appropriate antibiotic therapy on any abdominal sepsis. So it's recommended that you should start with the empirical antibiotic based on the possible organisms involved in this infection, and subsequent antibiotic therapy should be based on culture sensitivity, and de-escalation or withdrawal of antibiotic therapy should be considered as soon as possible based on re-evaluation of the patient by doing a total count and Procalcitonin estimation. And as I already said, that this abdominal sepsis secondary to GI perfusion can be involving all the organisms, which are basically enterobacterial gut organisms. So the guidelines for antibiotic therapy in abdominal sepsis is a primary peritonitis. You can start with 5% tazobactam, 7% sulbactam, or impenem cilostridine, or a meropenem. In secondary peritonitis, these are the different combinations which are recommended for low risk and high risk patient. It can be a 5% tazobactam, and in high risk patient, it can start with 5% tazobactam, or you can consider giving the patient meropenem. For monomicrobial infection, which are morely a gram-positive infection, linezolid is a good choice. For polymicrobial GI infection, tigecycline is very effective. Antifungal therapy is not indicated routinely. Secondary peritonitis with shock or tertiary pregnancy, impairing antibiotic therapy with antifungal may be considered because there is high chance of fungal infection in this situation. What should be the duration of therapy in abdominal sepsis? Minimum period of 1 week. In some 3 to 5 days therapy may be effective and minimize side effects. In staphylococcal septicemia, antibiotic need to continue for about 2 to 4 weeks. Serum calcitonin may be a procalcitonin may be a guide for duration of antibiotic switch. For systemic candidiasis, you start antifungal treatment. It should be continued for about 2 weeks. Another important area for use of antibiotic is colorectal surgery. It has been observed that surgical site infection is a common cause of morbidity in patients following colorectal surgery. And this incidence of surgical infection is around 25% following colorectal surgery. And gut bacteria is one important cause of post-infection. In our patient population, the fecal-loaded gut is a very important factor for post-infection. So, mechanical bowel preparation antibiotics are the standard method of gut preparation in late 20th century. But there has been a lot of controversies now. So, what are the nickel regimen? These are the regimen used earlier before advent of this newer antibiotics. It was a bowel preparation with bisacodyl and magnesium sulfate days before surgery, and patient was given oral neomycin plus oral erythromycin 19 hours, 18 hours, and 9 hours before surgery. And this study has shown gross reduction of post-infections following colorectal surgery. So, what is the current status of preoperative bowel preparation? Different series has shown conflicting views regarding mechanical bowel preparation and use of parenteral antibiotics. It is observed that this is effective, particularly in the left colon and rectal surgery. Current evidence is not, however, clear regarding preoperative bowel preparation with particularly mechanical bowel preparation. This newer regime of some meta-analysis of 147 trials, they have shown that a single dose of parenteral antibiotic is effective in reducing post-op infectious complications. Mechanical bowel preparation has been associated with electrolyte imbalance and does not reduce the incidence of infection. And in ERAS protocol, they have recommended no mechanical bowel preparation as it delays recovery. However, current evidence supports use of mechanical bowel preparation and parenteral antibiotics for elective colorectal surgery, particularly surgery in the left colon. So, what are the antibiotic used for colorectal surgery? Level 1 evidence for IV antibiotic within 60 minutes before operation. It can be either a second or third gen cephalosporin with metronidazole. No further dose are required if there is no intraoperative contamination. This mechanical bowel preparation will be combined with oral antibiotics in some situations. However, use of only oral antibiotics without mechanical bowel preparation, there is no robust evidence. Some people still use nickel regimen with neomycin and erythromycin. Recent trials, however, use kanamycin and tobramycin as oral antibiotics. Antibiotics used should cover the gram-positive, gram-negative anaerobic bacteria. Antibiotics for emergency colorectal surgery. Most of the emergency colorectal surgery is done either for obstruction or perforation. And these are the patient who already has established sepsis. And oral antibiotic in emergency setting is not recommended. Mechanical bowel preparation is not feasible in emergency setting. So, emergency patient undergoing surgery for perforation should receive therapeutic antibiotic, and this antibiotic should be continued till the infection is under control. There is another incidence of abdominal sepsis following some form of intestinal ischemia. This intestinal ischemia can cause vascular compromise of the gut, and it can be a life-threatening emergency. This intestinal ischemia can be either a occlusive ischemia because of mesenteric vascular occlusion, or it can be non-occlusive because of gut stretching. In occlusive ischemia because of arterial embolism, thrombosis, venous thrombosis. This intestinal ischemia is manifested based on the duration and severity of vascular occlusion. It may result in full thickness gangrene or partial ischemia involving mucosa and submucosa. Partial ischemia may later lead to gut stricture. In this situation of intestinal ischemia, early diagnosis and prompt intervention may reverse the ischemic process. High index of suspicion is particularly important for managing such patient. This mesenteric ischemia affects the mucosa in early stage, and mucosal ischemia impairs barrier function, and that results in bacterial translocation. This bacterial translocation can occur through the intracellular route, through the ulcer area, or intact mucosa, and this can lead to sepsis. And all the gut organism can translocate to the gut wall and result in systemic sepsis. So the risk of bacterial sepsis outweighs the risk of antibiotic resistance. So therapeutic antibiotic is indicated in patient who has got gut ischemia. So abdominal surgery is the most common in surgical practice, and GI tract, including the biliary tract, is the resident of all types of bacterial flora. Surgery in GI tract may be clean, contaminated surgery, or even if some situation of perforative peritonitis can be dirty surgery. Clean contaminated group may be managed with a suitable prophylactic antibiotic therapy. However, if you are having a surgery where the surgeon is already contaminated or dirty, one need to have a consideration for giving the patient therapeutic antibiotic, initially starting with the empiric antibiotic, and antibiotic being changed based on the culture sensitivity. Although the choice and duration of therapy is controversial, and as on date, there is no clear consensus because you have a lot of antibiotics available in the market, and one has to consider the local sensitivity. Every hospital has to have a antibiotic policy based on the flora found in that particular hospital and their sensitivity pattern. So, thank you. We pass on to the next part of the lecture, that is WHO surgical checklist. So it's a WHO safe surgery initiative, and this WHO surgery safe initiative came after a lot of discussions. And if you see this picture, it's a picture of long back, December 3rd, 1984. And this is a famous picture which came after the Bhopal gas tragedy. What happened that day was there is a gas leak in the Exide laboratory in Bhopal. It has been estimated that 5 lakhs people has been affected due to leakage of methyl isocyanate gas. The official death toll was recorded as 3,000. Unofficial death was taken as 8,000, 10,000. However, subsequent investigation has revealed that the whole accident occurred because of a human error. When that factory is going to close, all these valves delivering this gas need to be closed, but one of the valve was not sealed properly, and that led to the leakage. You have seen this picture. The astronaut who has gone to the space, while going down after their successful mission, she died with a blast. So again, what happened, as this aircraft is having a leakage of hot gas through the hole in the wing, but the NASA scientists sitting in the console, they wrongly interpreted this as a sensor error, and no action was taken, and the blast occurred. This is another famous picture of a wrong surgery. This lady is a mother of Sridevi. She had a brain tumor, and she has gone to the world best center, Memorial Sloan Kettering, for her surgery. And surgeon was the most famous neurosurgeon that time. The surgeon came up and operated on the right side of her brain, but she had a tumor on her left side. The CT scan brought to the OT belonged to some other patient and was placed on the view works. Subsequent inquiry led to suspension of the surgeon. So based on these human errors, and who has taken initiative to bring out some safe surgery initiative? It has been observed that there is a lot of patient safety concern in the hospital environment, and there are a lot of harms that can occur while delivering healthcare. And every point in healthcare has got an inherent degree of unsafety. So a clear policy, a skilled healthcare personnel, and organizational leadership is important to prevent this. Who has estimated that 234 million operations are performed annually around the globe? And the review of patient records showed a median incidence of in-hospital adverse events to the tune of 9.2%. 50% of those adverse events are being operation or drug related. And it has been observed that 43% of these are deemed preventable. In England and Wales, there is a reporting system where they reported that 10,500 patients have died or came to severe harm secondary to hospital incidents in 2013-14. And over 3,000 of these incidents were related to the treatment or procedure. And if you consider the global incidents, and India also is a huge public health problem. 1 in 4 patients are harmed while in hospital or in ambulatory healthcare. In low and middle income countries, it has been observed that 134 million adverse events are reported per year. And 2 to 6 million deaths are due to inferior care, and medical error estimated cost in US to $4 billion. So who has taken this safe surgery initiative and try to come out with a devising a checklist? In 2002, World Health Assembly urged countries to improve the safety of healthcare and monitoring system. WHO has set global standards of care and provided support for countries to improve patient safety. In 2008, WHO launched Safe Surgery, Save Lives, and this was led by Professor Atul Gawande, and who published the WHO guidelines for safe surgery. This set out 10 essential objectives for safe surgery from which the surgical safety checklist was derived. The aim of WHO checklist was to give teams a simple, efficient set of priority checks, improve effective teamwork and communication, and encourage active consideration of patient safety for every operation performed. WHO surgical safety checklist is a structured drill at the operation theater. The nursing staff, anesthetist, and the surgeon are the person who will carry out this drill in the operation theater. A recent government order from Government of West Bengal has made it mandatory to follow this surgical checklist in the operation theater. This will avoid mishaps at the operation theater. And this includes 3 broad steps. The first is sign in. When the patient is in the operation theater table and the anesthetist is trying to give anesthesia, that is the time one should consider a sign in. Once the patient is anesthetized and surgeons has come up, this is a time for time out before the skin incision is made. Once the procedure is over and surgeon is completing the procedure, the sign out has to be completed. So this is a broad WHO surgical checklist where there are defined points. One can deviate from these points, one can add some more points, but this basic point has to be followed. Depending on your local criteria, you can add up 2 or more points in this, but this basic point has to be there in surgical checklist. So first is before induction of anesthesia, sign in. Before skin incision, that is a time out, and before patient leaves the operating room is a sign out. These are the 3 parts. So who will be performing this drill? The sign-in is to be done in presence of nurse, anesthetist, and surgeon. But presence of surgeon is not essential when you are doing sign-in. So what you do in sign-in? The nurse loudly asks the patient his identity, asks the patient what procedure is to be done. If there is a surgery in one of the limbs or there is side concern, the patient will be giving on which side he is going to be operated. And nurse has to check whether the consent has been properly signed or not. So if the site of operation, suppose the gallbladder surgery, there is no site applicable. Then one of the most important thing in sign-in is the nurse has to ask the anesthetist whether anesthesia checklist has been completed. There is another long list where the anesthesia checklist is there, whether the machine is being checked, the gas flow, the other flow meters in the gas, the machine is okay or not. Pulse oximeter is mandatory for any operation. So nurse will confirm that the pulse is connected and that is functioning. Patient has to be asked about any known allergy because it has got an implication for anesthetic drugs and other antibiotics that we use during the operation. Nurse should ask the anesthetist whether he has got any anticipation of difficult airway or any risk of aspiration. If the anesthetist says there is a possible difficult airway, one has to keep the necessary equipment ready. Nurse should confirm the anesthetist whether this patient has got any possibility of more than 500 blood loss, or in children 7 ml per kg of blood loss. If no, fine. If yes, ensure that patient has got a second IV line and check whether the blood has been kept ready or not. Once this is done, the nurse will loudly say, sign-in is over, anesthesia can be given. Once the patient is anesthetized, the surgeon comes, and the next part of this exercise is timeout. Senior nurse, surgeon, anesthetist will take this drill. The first point is the team members identify themselves and their role. So surgeon will loudly say he is a surgeon, his name is this, his assistant will tell their names, and then the nurse confirms name, the procedure to be done, and any site implication. The nurse will ask the surgeon whether he expects any critical steps or unexpected events in this patient, what can be the anticipated blood loss. So if the surgeon says there is some critical steps, he might require some. If there is more blood loss, one should check again whether the blood has been arranged or not. The nurse should ask the anesthetist whether he expects any specific deviation or any concern during the operative period. The nurse from the markers whether the instrument she has taken is also, and any equipment issues or any concern. Another important part of this timeout is ask the surgeon and his assistant and the anesthetist to a antibiotic dose within 6 minutes. And in some situations, imaging is important, particularly orthopedic operations or some operation which is the image guided operation. Imaging is important, and one should display the correct image in the view box. Once this is done, nurse will loudly say, timeout is over, you can start. Once the surgery is nearing end, the surgeon should ask the sister to do sign out. And sign out is done with the senior nurse, surgeon, and the anesthetist. Again, at this point, the nurse verbally confirms for the surgeon the name of the procedure performed, because sometimes a plan may be doing a particular procedure, but while doing the surgery, surgeon may deviate and some more procedure may be added. So at the end of the procedure, surgeon has to make out and say loudly what operation has been done in this patient. Next is important is instrument count. So sign out is not only instrument count, is a complete instrument count with the scrub nurse and the surgeon. And the nurse should confirm whether any specimen has been removed and whether that particular specimen has been properly leveled. Nurse should ask the scrub nurse and the surgeon whether there is any problem with the equipments, and if a problem is there, that equipment issue has to be settled afterwards. Then the nurse asks the surgeon and the anesthetist whether this patient has got any concern in the post-op period, and whether this patient need to be shifted to the ICU or to the ward. These are the basically 3 points in checklist one has to follow. But there has been a lot of problems in implementation of this checklist. We all agree that this is very important, but all are not practicing. We need to sensitize all healthcare workers for adoption of this checklist. Recently, one doctor in Calcutta is penalized with rupees 30 lakhs for doing a cholecystectomy in a patient while she was waiting in the theater for a fracture fixation. So this sort of error happens. And if you follow this checklist, this sort of error is unlikely to happen. And as per recent government guidelines, this is mandatory to practice WHO checklist in all clinical establishment. But only government order is not going to change the scenario. Sensitization of the doctors and nurses are very important. And we need to sensitize our people with flags, posters, and we need to do this practice in our different conferences so that people are sensitized and follow this checklist. Thank you. Any question regarding antibiotic part and this part, I am ready to answer. You can unmute and ask a question. Dr. Boshak, any comment? Any question? I'll be glad to answer. Okay, so if there is no question, you can conclude today. We'll having our new schedule of program from May. So classes will be on Tuesday, Friday, and Saturday. Same time, 8 to 9. Okay, thank you.